from the SOP to make their life easier, don't do it. Like, because your name is going to be associated with that deviation. The process is in place to not only protect the patient, but also to protect you from potential litigation.
Hi, welcome to Blood Talk Small Talk, where we aim to provide a deeper understanding of the teamwork it takes to ensure quality care in a healthcare setting. Tune in for a mix of serious science and casual conversation, and you might be surprised to learn just how much goes on behind the scenes. I'm your host, Mars.
I'm your host, Pich.
On today's episode, we'll be talking a bit about something that doesn't always get the spotlight, but absolutely should. One of the misconceptions about the lab is that all we do is run and release tests, but there is so much more to it than that. Today, we invited Nicole, a CLS Quality Assurance and Safety Coordinator. Nicole, would you like to introduce yourself and a little bit about your background and how you grew into this role?
Yes, hi, I'm Nicole. I am a CLS, and I first started about doing blood bank for about 6.5 years, and then an opportunity to move into quality and safety presented itself, and I decided to go for it. With blood bank, everything has to be like very particular and recorded and documented, and so we already had a little bit of that, very detail-oriented aspects in my work. So I went for it, and I really like it. But I do want to say that I am not the coordinator at my facility. I am part of the quality and safety team, though.
Congrats, still hard work, man.
Yes, it's really hard. It's very detailed. And actually, Nicole plays out herself. She's very, very detail-oriented professional. It's just even when we were in blood bank together. So
Yes,
I
we
think
did
it's
work
a very
together.
good trait to have, especially to grow into like a QA and safety roles. So
And I've been doing quality and safety for about 3 years now. And
it's been 3 years already. Wow,
yes, it really
kind of
flew.
fast, isn't it?
Yeah, it sure did. And I've learned so much and have so much still to learn. I mean, the environment is constantly changing, which we will talk about in detail as we keep going.
Yeah, let's start. So if someone outside of the healthcare, how would you describe or tell them what's QA and safety? Like, how would you explain it?
Well, I would describe it as being the person to essentially make sure that the laboratory is compliant for all regulatory and accreditation requirements. What does that mean? Well, there are all these different organizations that the laboratory has to follow these standards. So essentially, you can feel like the results that are being put out are accurate and reliable because if the laboratory is not putting out something that you can rely on and doctors can make diagnoses on or interpretations based on those results, what is the lab even doing? So with quality, you've got CAP, the College of American Pathologists. You've got CLIA, which is the Clinical Lab Improvement Amendments, the Joint Commission, CMS, OSHA, the FDA, goes on and on and on. Plus, and
The
those
whole
are just,
alphabet.
yes, it's really just, there are so many things that you have to consider. Finding the appropriate standard, making sure that like the spirit of the rule is actually being met, that can be challenging as well. But all of these things taken into account and brought into a single process would be called like a quality management system or a QMS. And so that is ensuring you're meeting all of those standards, you're limiting risk to your patients, you're limiting risk to your staff, and limiting risk to the organization. So it's all about making sure that, because the laboratory is extremely complex, as we all know. So making sure that every step is working as expected and everything is flowing smoothly, that is the embodiment of quality and safety, meeting those regulatory and accreditation requirements, but also shaping policy to make sure that you prevent errors before they occur.
If somebody asked me that, I would have tell them, well, just think of a cop.
That's something else that I wrote, lab police.
Yeah,
It sounds a little sadder, I guess.
no, but like the
meaner.
cops the one.
Yes.
Not really, but like will be the one who protecting us, right? Yeah,
Well, I
protecting us
mean,
from harm
I
and reinforced rule. So
I agree completely.
I was going to say, since we were talking a little bit about CAP, one of our accrediting agencies, Pich did a presentation on CAP deficiencies. And if you want to go watch that, the link is in the description. There you
thank
go.
you, thank you. Yeah, we'll link it down below. But yeah, just do that after you watch Nicole, because
yes.
I'm sure she'll have a great insight for us today.
Watch this first so you understand what the deficiencies mean.
Definitely,
It is a lot.
yes, yeah, it is a lot. Like I mean, QA is, but I feel like you're right in the way. Kind of comparing QA safety to like a cop might kind of sound harsh, but I don't know. Like to me, that's like the closest, I guess, to give somebody a picture. But yeah,
I would agree. There is truth to that. When your quality person or your safety person sees you, maybe if you were in the laboratory and you maybe are handling a specimen without a glove, and all of a sudden you turn around and they're there, you're like, so how you are received, and that was a bit of a surprise when I took this position with police. It's a divisive position and with the public. And the way that I think about it is I try and put myself in the position of the patient. I hate going to the doctor. If I'm sick, I feel vulnerable and scared. So if I know that the lab is doing what they're supposed to do and the hospital is doing what they're supposed to do and everything is clean and working as expected and everyone seems to know what they're doing and are calm and secure in their processes, I feel calm and secure as a patient receiving care there. So
Mhm.
I think about that in essentially every task that I do in quality and safety because safety is everyone's responsibility, not just your supervisor, not just your quality or safety coordinator, everyone. You have to
Yes,
make
sure.
sure that you're keeping yourself and also your coworker or whomever is coming after you to take over your work, like for a handoff situation, is also being safe. So you need to have open communication, transparency, and you also need to take on the accountability that you are doing your part because everyone has to do it in order for quality and safety to be met.
Yes, absolutely. One thing that would surprise me when, because I was doing QA safeties and was a safety coordinator for a while. I don't remember how long, but I was surprised. Like everybody said, like, oh, like in the break room, there's not enough space. I never find space in the break room, and I was like, my first response was like, really? I never have that issues because when I walk, but after that day, I noticed when I walk in, somehow everybody lunch and break are over. They're all leaving.
Whole break room to yourself as soon as Peach
Yeah,
walks in.
like I was like, really?
Yeah.
After that, I was like, wait, maybe it's me, so I don't go there again, so they can take their break.
Yeah, I was not prepared for that when I took on a quality and safety position. I was one of the CLSs, just on a wet bench, working with all the other staff. And as soon as I took this position, I was separated from everyone. It was an adjustment, and the staff sort of treated me like leadership, which I did not see myself as, but
Yeah.
it was a surprise.
Would you think that people outside of, I guess, healthcare should we care about quality and safeties that's going on behind the scene, like in the lab?
Absolutely. I mean, you can say that about any regulatory agency or practice. Like, you don't want to eat at a restaurant that isn't like is a C
Clean.
or lower, like or is infested with roaches or other vermin. Like, you can get sick and something bad can happen. So, the public should care about what happens behind the lab bench because that is essentially what their doctor is basing their treatment on.
Hmm.
There is a saying throughout the laboratory and pathology, like without the lab, you're only guessing. I'm sure you guys have seen merch with that on there. And it is absolutely true. Like, leadership may be surprised at how much it takes to make sure that the laboratory is putting out reliable results. And so everything has to be assessed for performance and efficiency. Like, it has to be measurable as well. You want to be able to see your successes and you want to be able to see your failures and respond to them. But remember, quality is not reactionary. It should be preventing the error before it occurs. So, say a mistake happens. The impact of an error could be just an inconvenience. Maybe the patient has to be drawn again or has to wait a little bit longer. It might be a little bit more money. The lab might have to replace reagents that got left out, but it could easily, because it's such a complex process working in a hospital, it could easily become a compound issue that every step after that is now affected. And it could
Hmm.
be something serious, like either delaying care, getting inappropriate treatment, or the condition worsens, or the patient could die from a mistake. So,
Yeah.
I mean, any business needs to make sure that they are doing what they're saying they're doing, and the customer, which is the patient, but also the provider and doctors and nurses, all the coworkers that you work with in other departments, they are also the lab's customer because we are providing them a service so they can provide service to the patient in a more patient-facing position.
Yeah, absolutely. To add on to what Nicole said, right? For example, if we have no quality controls, we don't do like double checking, we don't have data checking, then if you have a patient who came in and have a hemoglobin test and the patient was 13, for example, and then next draw, which is like 4 hours later, the patient hemoglobin at 6, and without any of the checking, it would alert the doctor to ask for transfusions, right? So the patient would be getting transfusions when the patient not needed. No, that process, it kind of protecting the patients because we have the qualities in place. Like we have something to checking our results, making sure that it is possible, right? If the patient is bleeding, so it's possible that the patient went from 13 hemoglobins to 6 in like 4 hours. But there are process in place that we prevent that and trying to checking for like why is that big of a change, before we actually alert the patient, I mean, alert the doctor. And so that's kind of what I think how like the quality assurance can help like the patients from getting like misdiagnosed or mistreated. Nicole, what do you think? Is there anything you want to add?
Yes, like when in order to protect the patient, everyone is a different subject matter expert or an SME. You'll hear that term a lot. Like, you wouldn't ask, someone who is specializing in chemistry to look at a microbiology plate or report. Like everyone has their own part to play. And of course, there are generalists that can, rotate through every department. But I haven't seen that in practice a lot. There is really AP, micro, blood bank, core. Am I missing anyone?
Point of care.
Point of care, of course. And everyone is honed in on these particular aspects of patient care because they all work together in order to diagnose the patient. So if easily someone could miss something, like say you are a phlebotomist and you're drawing the patient, you are hyper aware of how to draw the patient to prevent the quality of the specimen from affecting lab results. If the specimen is hemolyzed or if it's clotted or if it sat around for an hour before you sent it up, that can all affect the analyte measurements from the instruments. You have a cat. I'm sorry.
It's okay. She
Say
came to say
Lulu.
hi. She loves
So
being co-host.
cute.
Continue. So we were talking about specimen integrity. Don't worry, I got you.
Yes. So when you have to call the floor and say the specimen is hemolyzed and needs to be canceled, please redraw it, there's sometimes a lot of questions that the staff can have, like, well, why is it hemolyzed? Or it could be the patient's condition, and that is something that you may want to talk to a provider about over the phone, because when you get results that you're not expecting, it may be matching the clinical picture, but because a CLS is not in front of the patient, discussing it with a patient-facing person who is involved in the patient's treatment can help sort of identify what sort of problems have occurred over the course of the patient's stay. So the quality assurance or the quality management system can help protect patients because it ensures that the work is done correctly the first time and that everything has been a standardized process. So the staff feel confident in what they are doing. And if they see something that is looking weird or is giving them pause or is giving them flags that, oh, maybe the specimen is contaminated, like Pich was talking about the drop in hemoglobin. Like, we don't know if the patient is bleeding. If they came in the ER, it could be a trauma. We're not really sure. The patient's diagnosis may not be accurate in the computer anymore. They may have come for shortness of breath, but now they're here for a GI bleed because they were able to find something. Having a reliable SOP and quality system, the staff will feel comfortable reporting a potential error or investigating it further, and this will help prevent patients from potentially getting misdiagnosed. And this allows the patient to get the best care because, the less specimens we have to collect from the patient, the less rework that we have to do. The patient is essentially having to endure another blood draw, for instance, if it's just something like that. But if we accidentally say it's gram positive versus gram negative, then the patient might receive the wrong antibiotics and you have to give it right away. And so they might have missed the blood culture or something. I mean, there's so many things that have to go perfectly for the patient to receive the care that they need. And another aspect of quality is you can't do everything. You need a strong team. Everyone needs to know what to do in order to make sure that you deliver care to the patient. And this is also including departments that are not part of the lab or under control of the lab, which is sometimes challenging because what you care about as a laboratorian may not be what another department cares about. So trying to find that even ground, aka patient care, that is what binds us all together to make sure that we are putting our patients first.
Sometimes I feel like there's a lot of fighting within within the hospital between lab, nurses, doctors regarding results. Just because sometimes, we are trained to look at the results like Peach was saying, the failed delta check or like possible contaminated, and you want to cancel it or request a redraw. Of course, nobody wants that, but we don't want to release the wrong results and then potentially give them mistreatment. But they're like, nah, I drew it myself. I know it's good. Why are you doing? But there's a lot of other things that could happen in between or possibly even wrong patient. And so it's just all of these internal practices that we do within the hospital, right? Like the safety intelligence system that we have, or like the submitting reports to, I guess, not so much escalate the issue and play the blame game, but also prevent it from happening in the future. That's one of the things, right? Just like bringing the acknowledgement that this is something that has happened, and then we can take account if we see it happen multiple times, then it is something that would need to be corrected, right?
Absolutely.
Yeah.
I want to expand on something that you said, putting in a report on an incident. Essentially, it's not about the blame game, as you were saying. There is something called just culture, where it is when you approach errors as it's not any one person's fault. We're not looking to place blame on any person. We're looking at the process to see where it can be improved. Quality improvement is a huge aspect of my job, as is responding to complaints, which I get all the time. And I can't tell you how many times I've had people from outside the laboratory say, I did it this way. I for sure did da-da-da. This didn't happen. I did this. I walked it myself to the laboratory. And why have you lost the specimen? It's like something happened and we're trying to find that out. So it's a lot of, you can't let a lot of times people's emotions like get really flared up because, if, for instance, if you are a provider and you tell the patient that they have diagnosis with a poor prognosis. And then all of a sudden it turns out that the specimen that you based that diagnosis on, there was a problem with it, and then it gets expunged from the patient's record. Now you have to have this relationship with this patient that has taken a blow. Like, the patient may not trust you as much. So now you have to tell the patient, like, oh, there was a problem with this specimen, so now we have to do the test all over again. It can be very stressful for everyone involved. I mean, like I said, I don't like going to the doctor. So it's just, you are on the spotlight and you never know what you're going to find out. So I can understand why errors often get this, like, well, I did everything right. It's like, we're not trying to put blame on any person. We want to find out what happened. We just want facts. And no, please go ahead.
But honestly, I feel like that's why sometimes we request the redraw, because it's like we really want to double check and make sure that what we're releasing is correct, because we don't want the provider to be like, hey, you have this. And then later on, oh, just kidding, you don't actually,
Yes, absolutely. Or do a point of care test. I mean, you can do it right at the patient's bedside. So yeah, Pich was saying, like, if the hemoglobin has suddenly changed, the nurse could at the bedside do a HemoQ test, which comes out in 2 minutes. So, and then you see it and you go, oh my gosh, yes, we need to transfuse immediately. Or then you're like, no, there's something going on here. I better do a redraw. But, making sure that everyone is open to investigating and willing to be transparent about the whole process, that can be challenging.
Yeah, absolutely. Because that investigations aspect is kind of like a cop, and that was kind of give bad reputations where a lot of people in QA positions were like, oh, are you out to get me? When in reality is not. Like, we just wanted to protect you and the patient. So we actually have like the common grounds where like we are here for the patients, but the QA and safety coordinator, anywhere on top of they're there for the patients, they're also there for you as an
Yes.
employee who working on the bench, where like your safety, the quality of work that you do are like, that's their job. So it's kind of could come out that way, but there are very essentials, because a lot of time people don't think about it until, God, Nicole, something happened. Run to Nicole.
Yes.
So like they don't think of you until something already happened, and now you're like, okay, what happened? Let's clean up.
Yeah, then you're in crisis mode. And like I said, quality is a lot about preventing the error. And so if you find out that an error has occurred or somebody complains about something, you look at the process, because if you have a process that is either not being adhered to or is risky from the start, you would like to make it to insulate your own staff with a process that is less likely to produce errors. So a lot of it is collaborating with different departments as well as different sections within the lab, because everyone is focused on their own goals and targets and indicators, and making sure that the QC passes and making sure that the proficiency testing is within the set parameters. There's so many things that have to be checked to make sure that's coming out as expected. And if there's any deviation, there has to be evidence to prove that you've done your due diligence to correct it.
And I think I just remember something. This didn't happen at like my current hospital. This happened like a while back when I was still working in the private sector. The phlebotomist is also working as like a lab assistant. So kind of getting cover both positions. So you're drawing and then you process the specimen, pack and send it out. So like the whole process from start to finish, and then you rotate. And then we noticed that like, how come every Thursday, most of our specimen will be hemolyzed. And like on Thursday, every Thursday, it's bound to be hemolyzed. And it's not because we thought like, oh, maybe it's summer. And then, we left it outside. It's hot. It get hemolyzed by the time the courier picked it up. And then we looked at it, it's like, no, it is also in the winter. And then I was we like, okay, what happened to the specimen? So we tracked it from like, okay, we collect from the patients where we put it. And we found out that this particular phlebotomist, she's tall. Okay. So like I was also a phlebotomist at that place. So after I collected the specimen, I'll put it on the bench when I check for the name, when I pack and put it into the kits. Since she's really tall, we have a little autoclave. She would put it on top. And the reason why is every Thursday we get a lot of call because we use that machine on Wednesday.
Oh my gosh. Wow.
Something you wouldn't really expect, though.
Yeah, like we like, I mean, because it like we use that like all the time. Every like a lot of lab would have that like the little autoclave machine, because we don't have a lot to autoclave. And yeah, like we just put it on there because the heat from the machine, and it's not every single specimen. So like if we know like it's every single specimen, then maybe something in the process. But now we don't really know because everybody follow the same things. We literally have like everybody follow each other's specimen. So I draw, I put it down here. So somebody stand there and watch me. I put it here, I labeled it, I do this and this, put it in the box. And then obviously she didn't think that she did anything wrong. Or like, I think it just maybe slipped our mind. We were looking at it and we didn't notice it that either. We're like, oh, okay, you put it there. She do the check, she do the double check, put it in the box, everything is fine. And then later on when we were cleaning, we're like, this is hot. And that when it was like, when I realized, wait, was this hot when we put the specimen on top? And then, yeah. So after we realized that and we moved the autoclave out of the way, so it's not in the on the processing bench, kind of put it far back, never happened again.
Root cause analysis.
Yes.
Yeah, so that is like one thing, like it could be something as simple as that, but the QA person is here to help you because sometimes we could be blind to it, like that thing is been there every day. You walk in and out for 8 hours, you see that thing, and it's gonna slip our mind. But yeah, I'm glad that we solved it though. So it was came to the point one time that we're like, okay, let's just not draw on Wednesday because we couldn't figure it out what was wrong. Like, how come everybody that's here is on Wednesday? Like, not everybody, but like most of them have to be redraw.
And of course,
Yeah,
it would be
so
the ones
like,
closest to the heat source. So it wouldn't be all
mhm.
of them, and there's no necessary order in the rack
Yeah,
that
because
it's
like
being put on.
no, it's not. It's just like, okay, here in like the wrap, like the 96 tube, you just kind of stick it wherever, and then whatever that closest to I think the back of the autoclave machine, those one will be more hemolyzed than the other one because as you're moving toward the front, it's less heat.
Yep.
Yeah,
Yeah, the
yeah.
investigation can really take you to places that you didn't really realize. Like, for instance, we were having very weird blood gas results, and we realized that the source was not always accurate. A doctor may order an arterial blood gas, but maybe the person who is trained to draw arterial was not there or was floating on another floor, and you just needed to get it done. The people who were collecting the specimen were like, there's no difference. I'll just draw venous blood gas and put the arterial label on and send it to the lab. Well, now all of a sudden, it's a different source that has different reference ranges. And being like having to sort of piece together exactly why and when it's happening, and it can reveal things that you didn't really realize were impacting the process in the first place. It could be something as simple as coverage. It could be something as simple as the SOP needs to be revised, but it can be all sorts of things. So yeah, absolutely.
Yeah, so that's just like, one instance of like, we don't really think of it until something happened when, that issues happen. Then we're thinking like, okay, QA, come on, help us. Like what's going on? We're trying to identify. And yeah, so why would you think that safety is not just about the employee or the staff that within the lab, but it is kind of tied into the people that we serve, which is our patient.
Oh, absolutely. The laboratory, not everyone is patient facing. At my facility, the laboratory is considered patient facing because phlebotomy is included in the laboratory. Because pathology is going to be all treated the same, we are considered a patient care area. Even though a patient never like comes into the laboratory to receive any sort of care, as a CLS, you're kind of insulated from seeing the patient. Of course, there are some situations where you do have to leave the lab and maybe go to the floor, especially if you're in point of care. You're training nurses, you're explaining new procedures, you're doing competency, you're doing QC, making sure that reagents are stocked. You work in blood bank, you go and you are refilling the refrigerator or delivering blood in an emergency. So there are some times in which you see the patient, but for the most part as a CLS, you don't really think about it, and you can kind of forget like who we are there to serve, which obviously, as you have talked about, is the patient. So
Mhm.
it would be nice if everything always worked as expected, but it doesn't. But remember, it is lab staff, but it's not only lab staff, it's also the providers, doctors and nurses, which I have talked about before. They are also our customers. So both groups have their own issues and their own concerns, and they each need different type of feedback. Like when sometimes you'll have a complaint entered by a patient advocate, the patient filed a grievance about something, and then you need to be able to provide information that the patient wants. But sometimes what the doctor wants or a nurse wants, they need their own type of feedback. Like there's actually some regulatory requirements that require you to do feedback at certain intervals with doctors and nurses. Like, is the lab doing what they are supposed to do? Like, are there any issues that you are constantly seeing? So far, the thing that my facility is seeing is like phlebotomy coverage. We're very short staffed in phlebotomy right now, and it's very challenging to find people who want to stay. We have primarily been doing a lot of contract workers, and they just work for their contract and move on. So, it's their prerogative of how they want to, do their position. But if we can't retain people, we can't offer consistent coverage. So
Mhm.
many operations overlap with what the lab wants, but we may not be speaking the same language. So in this case, if there is an error, Mars talked about root cause analysis. So if there is an issue that the solution may not be clear, or there are multiple departments that maybe we don't really understand anything about as a laboratorian, we have to do something called root cause analysis, which is where representatives, either involved in an incident or just representing the department as a subject matter expert, all come to a room and all acknowledge the fact that this is not about, placing blame. And we all kind of go through the process. You can do like a cause and effect chart, or you can do a flow chart or some process chart, and you essentially go from start to finish of what happened and why like an incident occurred in the first place. And being in quality, you sometimes get invited to those meetings. Generally, the meetings are pretty small, and the corrective action aspect of it is usually a completely separate meeting. So sometimes you don't hear about what the resolution was until much, much later, or you may not hear about it at all because the resolution may not be affecting your department specifically. But in a root cause analysis meeting, you have to essentially find every primary and secondary cause that led up to the error and identify the factor in which caused the problem to happen in the first place. So honestly, that's one of the most interesting parts of being in quality, because you get to hear the process from all of these other areas that you have no idea how they work. Like, I was in an RCA and I learned how registration works. Like, there are different types of registration. Like, if a patient is really sick or a trauma and needs to be registered immediately so service can be provided rapidly, there's like a quick registration process. And I had no idea how that occurred, versus if a patient is being transferred from another facility or a like nursing facility, something like that, there's usually a lot of paperwork and like a packet, a dossier essentially that comes with the patient. All that can be entered a little bit more slowly. But learning about the process from how a trauma patient is registered, and then later, say the identity of the patient is unknown at first, but later they find out who the identity of the person is, like how they merge the old alias that was given to the patient into their new alias, and all of the implications that also bring about. Like, I had no idea that the only reason, like at my facility, if the patient has an alias is unknown John Doe at the beginning of their stay, the change doesn't necessarily happen until the patient is discharged. Because if the MRN changes, essentially every specimen or blood product or medication that is associated with that patient's chart just all of a sudden is unattached if it gets merged while the patient is still receiving care. And I had no idea. Even asking the question of, does it have to be this way? Sometimes someone else in another department will be like, yes, because all of a sudden that specimen that has been on your automated line has nowhere to go. The results don't have a patient's chart to go to anymore because that patient's specimen is not like linking with the chart anymore. I had never really thought of that. So that's honestly one of the most interesting aspects of quality. You really get a big picture of how a hospital works. And, if you're working at a level 1 trauma center or a burn center or a stroke center, there's all these other aspects that are really deep diving on how a specific group of patients are getting care, and like different processes that like kick in when that occurs. I love to like talk to people and learn what their primary focuses are and what their quality indicators are and how they measure their successes. And it helps me also with my investigation. So if later on a situation pops up and I'm like, wait, it could be like Pich was saying, like that autoclave, did it move again? Has it been moved out of the corner where we initially put it? Because we had that situation that happened a couple of years ago. And you basically log that event, and it makes you a better investigator for future events.
It's interesting. So I have two things, I guess, that I want to ask. One, since we're all, I guess, kind of in sister facilities or something like that, I wonder if they all do the same, because about the John Doe thing and then not changing the name or the alias until after they're discharged and then like come back. Because sometimes I will see like babies in NICU who are there for like months, and then I'm like, why are you still like baby A or something like that, right? But then sometimes I'll see like patients who come in, I guess, into like psych ER with the John Doe, but then like a couple hours later they change. So that's kind of interesting to me, I guess.
It has to do with like the encounter. I mean, there's so many nuances when it comes to, because there's like money is involved also. So sometimes the floor might want to use a FIN number instead of an EMRA number. And like in blood bank, that is not acceptable. Why is it not acceptable? Because a FIN changes based on where the patient is receiving care. So they might have a FIN number in a clinic and then are discharged from the clinic and then move to the infusion center, for instance, and now they have a different FIN number. So as a laboratorian, you are tracking the patient as a person, and other departments of a hospital network might be tracking the patient with their insurance or with their diagnosis. So, patient identifiers is also like super, super, super important in the laboratory. That also prevents, misdiagnosis errors as well. So making sure that that is reliable is one of the very first things that we want to always check and make sure is being adhered to, all the processes that have been put in place to make sure that who you think the specimen belongs to actually is. I find that when the patient is discharged and readmitted and there's like a lot of, their processes may be jumbled because they may have complex care, then something easily can happen. Like sometimes a bunch of labels get printed out at a label printer, and just one tear on the wrong label, all of a sudden that label might go to another patient's room, and then you have a problem.
That makes sense. Okay. And then my second question is, Nicole, I know you like to play a lot of like board games and stuff like that. Do you think that I guess the investigative part of like those board games and stuff like that, do you think that this role that you have now versus blood bank like fulfills that, how do you say it, kind of like the urge to investigate and puzzle solving? Thank you. Sorry. So do you feel like
Yes, absolutely. It's like a detective aspect to it where you're like solving a mystery. You're working in blood bank. If you are working up an antibody case for the very first time, you have to call the floor and have someone ask the patient all of these questions. And you take their interview and their results, and you are piecing together why their antibodies are, reacting a certain way. And then you also read the chart and you see their history and you see everything, and you sort of put it into one assessment. And I find that fascinating, which also prepared me for this type of job. When you were working in blood bank, you are looking at the patient as a whole. There's a lot of aspects that get put into the pathologist interpretation as well. And so I feel that working in blood bank actually did prepare me better for an investigative role. Of course, when you're investigating, it only gets easier with time and experience. Like when I first started, I had changed from one facility to another, and the processes were so different. Having to relearn how this facility does things versus the other facility does things there was a learning curve. And also there's like when you are working the bench, there is a very specific set SOP and process of how you get trained in your initial training, your initial competency, your 6-month competency, your annual competency. There is a checklist that you check, and everyone sign. You are absolutely set. You know what to expect. You know what is being asked of you. But then when you get into like an administrative role, every day is different. I don't know what I'm going to find when I come to work that day. I might step into the lab and it could be a full-blown emergency. Granted, that could be the same in blood bank, for instance, or in chemistry. Your analyzer might be broken, and then all of a sudden, you might be on downtime. So that is true. But with the quality aspect, you don't know what to expect at every given shift. It could be so different. One day you might be focusing on a cytology specimen that went missing, and then the next day you might be looking at the chemistry proficiency testing results that were showing bias, and then you need to discuss it with the clinical consultant. So it's very difficult to plan because emergencies don't happen on any sort of schedule. So if you thought that you were going to make your slide deck for your meeting the next day, and then someone comes
When it
into your
happened.
office and says, Nicole, we have a problem. And then you're like, what kind of problem? And they're like, you need to come right now. And you're like, okay. And then, you have to remain calm also. Being in blood bank, when you are with a patient that is actively bleeding out, there's a lot of like emotions that are happening at the patient bedside. And we'll sometimes get, doctors or nurses or NAs, whomever, come to the blood bank and they are panicked because other people around them are panicked, but you need to be calm and cool and think like very level-headedly, because we don't want to let our own emotions get the best of us. We want the patient to be treated with our minds clear. So yeah.
Absolutely, because mistake could happen. Like when you rushing things and like, oh, hurry up, the patient's bleeding. But if you're putting or involve your emotion, developing the emotions with that case, one, you will feel so exhausted because that is every single day. Okay, like number two, it will affect the quality of your work because now instead of thinking about checking the patient identity, doing this test, just do your processes, you're also processing your own emotions. So it's wise, I think, to try to cut that part out and just focus in your task because that is how you can help the patient.
Yes, to expand with another scenario, I remember when we were working in blood bank, there was a patient who was, a trauma case, and the staff kept sending the TEG specimen. And there are, very specific specimen requirements for the collection of a TEG specimen. It has to be filled to the line. It can't be overfilled. It can't be underfilled. It has to be run within 10 minutes of collection. There are all these tiny little things, and maybe someone who drew the specimen looked at it and it was like a little bit under the line and said, it's fine. It wasn't fine. And then we had to call and say the specimen's unacceptable. And then they're rushing more because they need those results in order to get the patient treated. So then it got redrawn and it was the same problem. Or they sent it through the pneumatic tube, which it had to be walked up. And so just a little thing got changed every single time, and the patient had to be drawn like 4 times. And we got a call that was just like, what is wrong? I need these results. And you're just like, the results need to be accurate in order for the patient to get the right treatment. So I'm sorry, but the specimen is still not acceptable. So you often get hit with a lot of intense feelings because we're insulated from the patient most of the time. Being able to investigate and process all the information very calmly helps you. Situation.
Yeah. Have you ever come across the situations where you caught an issues, and if it's not fixed, it will cause like a harm to the patient?
It's a little difficult to say a specific event because, obviously there's HIPAA and, security. We don't want to identify anyone. There's something called protected health information, or PHI, or personal identifying information, PII. So, I have to be careful about how I describe certain scenarios, but there was one time, there isn't a lot of opportunity. When you're on the bench, you're catching things as they occur. So when you're in a quality position, you're not really seeing the activity in real time. Sometimes the error isn't caught until days later. It would be nicer, of course, if an error is caught immediately and corrected immediately, but sometimes it's not the case. So there was this one time, well, before I start, I want to highlight the differences between a corrected report versus an amended report. So sometimes, there are errors, minor errors, like maybe the specimen source has changed or the name is misspelled in the patient's report, and you can issue a correction, or an error in transcription. Maybe you used the wrong units, or maybe one number was wrong. And, it could be a 5-second time pass before you notice that mistake occurred, or it could be days. But either way, the report is then marked as corrected. And usually there's like a comment saying what was corrected. Amended is like if there is a significant change in diagnosis, or like the final diagnosis changes, or like new information, like a test that takes a really long time to run came back and now there might be an amendment associated with this report. So amended reports has to be very, very, very clear of the reason of the revision. The clinician has to be notified. It can completely change a patient's treatment completely. So I just wanted to specify that before I continue on. So there was a case in which a provider emailed me complaining because they had received a report from one of our reference laboratories, and the patient's initial report came back abnormal. And this can be indicative of cancer. And so the doctor notified the patient and they began to develop a treatment plan. But at some point later, the report was changed to normal. And so understandably, the doctor's like, did I look at the wrong report? What's going on? They weren't notified of any change. And also, it's our reference laboratory. So it's not our laboratory that is processing it. So you can't really call the lab and say what happened, because we don't really know, because it did not occur. Like as soon as the specimen leaves our facility, there is a system to be tracked, but we don't have control over that. It's the reference labs. They were confused and upset that there was no notice of change, either by phone or whatever. And they had already notified the patient of their abnormal results. And so they were like, my patient is already super stressed and anxious about this. Thankfully, in this case, the patient had not yet received any treatment, which would have been considered unnecessary at this point. So it's, like I said, easier to investigate a problem when the process is happening on site. But since this was a reference laboratory,
Off-site.
yes, I have to then contact them and get into touch with their right person. And so we were investigating. And while I was investigating there, I found that essentially during the process, they are using the specimen in multiple departments and they're aliquoting, right? And so when you aliquot, you are essentially relabeling a specimen, and then that piece of the specimen goes to that department. That's how you split the department, so you can run many tests on one specimen. So there may have been a mislabeling occur on one of the aliquots. I can't say for certain. We think that is what happened. But our specimen was not mislabeled. One of the aliquots was mislabeled, probably. So the wrong ID was attached to this report. So the name on that report was what changed. It wasn't the diagnosis that changed. It was, they swapped the name, which also swapped the diagnosis in this case. So that got me thinking, because usually if it's a mislabel, sometimes there's another patient that has been affected. Because if it's a swap, then all of a sudden there's two cases in which maybe the wrong result has gone to the wrong chart. So then I was looking at all of the specimens in that batch, anything that was being tested at that time. So then I started looking at those initial reports to see if maybe there had been a change in the patient identifiers. And I did find that is probably what happened. And so the patient or the physician that had initially filed the initial complaint was dealing with the situation in which the result went from abnormal to normal. But on the opposite hand, there was a patient that had results that went from normal to abnormal. But I hadn't received any complaints about that. So the other physician, you're reviewing your patient result and it's like normal. You're like, okay, we're moving on to the next thing. You don't really give it another thought. But if they aren't being notified of the error, there's no notice, and you wouldn't know to treat your patient any differently. So I was able to notify that provider that there was a mislabel offsite, and this patient is now gone from normal to abnormal, and you weren't notified because the reference laboratory was arguing that, well, it was just the patient ID that changed. And remember when I talked about corrected versus amended report, if it's just like a transcription error or the patient name is misspelled, like that is considered corrected. But it changed the diagnosis. And so they were fighting me tooth and nail to insist that like they did not have to go through all of the additional processes of notification and considering that this is an amended report. I was on so many meetings with their quality coordinator and the laboratory director of the reference lab, and we could not come to a consensus about, if this is a corrected report or amended report. And eventually we had to call CAP. And, CAP, you can call them at any time. Sometimes you have to leave a message, but there's also like, a chat or an email, and you can ask them because they are essentially a neutral third party and they are a regulatory agency. So what they say goes. So, we presented the case, and we knew we were right, but CAP sided with us, and, the comments are added to the report as a result. So with that type of scenario, you can see how like the investigation can easily get into the weeds. And if I hadn't taken the additional time to review the other patient reports, like that patient may not have gotten treatment or it could have been delayed, And
Absolutely,
so
yeah.
making sure like that persistence and insistence when you feel that something isn't right, and making sure that your meaningful corrective action is implemented. It's even more difficult when it's not your own facility and it's another business or other people. They're trying to protect themselves, and you don't really have control over how they do what they are
Like their
saying that they're
jobs,
doing.
yeah.
Exactly. So it is an absolute uphill battle sometimes. And if you're interested in a position in quality, you need tenacity on your side. If someone says like, no, we're not going to change our policy because XYZ, like if being a subject matter expert in quality or safety, if you know that the policy, if you've seen consistent errors of a similar nature happen over and over again, and it keeps getting brushed off by leadership, like it is your responsibility to make sure that those concerns are listened to by a third party, a neutral third party, someone who may not be as involved, or sometimes when you make a suggestion to a section on how to correct something, it might be a lot of work and you are not necessarily the one doing the work. So if you make a suggestion, sometimes someone can say, no, that's ridiculous. We're not doing that. But if you know that something is wrong and something needs to be done, you have to keep at it, which can also sort of color your reputation as well. As Pich was talking about lab police, like sometimes I'll walk into, someone's office and they're like, what now? I'm like, well, good morning to
Yeah.
you also. I just came to
Yeah.
drop off these reports. Bye. No problems here. So you can't take it personally.
Yeah. I think
Yeah.
I sided with Nicole. There was one instance I think I walked in and I just really just gonna say hi and it was like, what did I do wrong? I'm like, nothing, just hi, how are you?
Yes, yes.
Yeah.
So absolutely, that relationship can change based on the supervisor's workload or the hospital administrator, like how their mood is. Sometimes they might be more helpful than other days. They may just not, they might have too many meetings. They may have like other issues on their plate that you may not be aware of. And then if you come up with an issue that they think is a non-issue, sometimes that can be challenging.
Absolutely. They're like, what are you doing? There's no issue here. But giving like you're the subject expert. Then like, no, there is. Hear me out.
Yeah.
Kind of thing. So what is the most, would you say the most rewarding part of QA or safety?
Well, when I was working in blood bank, it was rewarding to know that your efforts could save a patient's life.
Yes.
You,
Agree.
like, I would be, most of my friends outside of work are non-laboratorians. And so they're like saving lives again. And I'd be like, stop, that's not how this is. I'd feel embarrassed, but they'd be like, you're doing things greater than what I am doing at work. I'm like, making like music or blah, 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 like trying to tone down their own accomplishments. But, when it comes to like the reward, when I switched to quality, all of a sudden all of that patient care aspect just stopped, and it was a surprise. I didn't really realize that I was putting like my own self-worth on like delivering patient care to a patient that I felt a connection to. Sometimes you have a patient, who's really hurt when they come into the hospital and they're there for a long time and you remember their name and you remember their case and you develop a relationship with the people caring for that patient. So when I moved away from that, it was sudden and I didn't anticipate it because I'm like, oh, well, I'm just moving to another department. It's still in the lab, but all of a sudden I'm not doing any wet testing and I'm not getting daily patient specimens. And I kind of felt a bit adrift at first. But now that I've done it for a while and I feel more comfortable in the position, I realize that I get satisfaction. I think a lot about, when I was in the program and when I was trained and my difficulties that I experienced going through the process. I always want to make the next person's experience easier or better or more enjoyable or less traumatic or whatever it is that will improve it. So I suppose I get satisfaction in knowing that I can help make my facility a nicer place to work and a nicer place for our patients to receive treatment. Because, we've discussed already, like, it's very stressful to go to the doctor. But, when you go to the doctor and everyone is nice and smiling and happy to deliver care to you and there's no hiccups, it goes smoothly and you're in and out and you got what you wanted and it's done. Like, that's a great experience. But, when you are the one working there, you want the same thing. Like if you have like the very, very first lab that I worked at was a research lab and their SOP was horrible, like was handwritten, crossed out, pencil spilled on, like could barely decipher what the actual process was. I'm not dealing with patients, it was animal specimens. So there wasn't really the same level of um, quality associated with the testing. Obviously, we're still doing science. We want our data to be accurate and reliable. But if I'm working in a lab in which nobody really knows what's going on or nobody is doing the same thing, you can feel like as an employee that you're holding your breath for the whole shift. And that is not a good feeling. Like if you wake up and dread going to work, like I'm sure we've all had those times, it's not a good feeling. And so when I give a safety lecture or a part of the orientation to new staff, I tell them, I'm like, hey, if you see something that is not right or a concern that is not being addressed by the people in your area that should be addressing it, you can always come to me or my coordinator. We are a third party, so to speak. Like we are not directly under anyone besides the manager and the laboratory director, and we will ensure that every concern is investigated seriously. And knowing that my staff know that, like it can feel like a safety net and it makes you feel more secure in bringing up problems. Like if you're in a lab that is constantly covering up errors,
Yeah,
that's not a
because
good.
they judging people from like, oh, you make an error.
Yes.
Like you said, it's not good because it just kind of built the environment where if the mistake were to happen, and it will, like we are humans, and they're just trying to hide it, and the people who actually would suffer from it is the patient.
Exactly. So I would say the most rewarding thing about working in quality is being able to shape policy and deliver real solutions to people both within my department and outside my department. Like, it's very rewarding to have someone like, a nurse, for instance, like send you an email and just say like, thank you so much for finding out what happened. Like, I knew there was something going on, but I'm so glad that this, like, there has been a policy change, and I'm hoping that this doesn't happen again. So thank you for, bringing attention to it, and, doing the due diligence and investigating every step to try and find a meaningful change to impact everyone involved. I would say that is the most rewarding part. But then there's also like, getting to meet people outside of the lab, and like I was talking about in the RCA meetings, like learning about different processes. Like, I can walk through the hospital and, there's that nurse manager and there's the quality chair and hi, you feel like a community at your site when you learn the names of all the different people who are coming together to provide patient care. And you also get to participate in inspections. So there has been a couple times when I've been invited by CAP to go to another lab and do an inspection. And sometimes you get to stay in some really nice hotels, and it's like a little vacation. And, they don't really like skimp on the expense. Well, hopefully that continues. But, sometimes they get people from all over. Like, they'll try to get a group from one area, one facility, and all go. But sometimes like they might not have a flow cytometry section. And so they may need to get someone from CAP or from another facility to come, maybe from further away. So now all of a sudden you can stay an extra day at the hotel. So there are some perks. I know a couple people in quality that get to go to Hawaii to inspect some of their labs.
So jealous.
I know.
Want to go.
Me too. I have not yet, but I'm a stressed traveler, so it's not a big deal. Most of the labs that I have participated in inspections, it's, just a drive away. But, they also pay for your meals, and then, you get to go out with your team at the end and talk about it, and it's a bonding experience. And being in quality and safety, you also get to be involved heavily in emergencies, which is exciting, in its own way. Sometimes it's extremely stressful, but it makes you a better person, like a better quality person, and you're able to deliver even faster results the next time.
I think I really like that part too. Even like I'm not in that anymore. I moved to do other things, but there was something that had happened kind of recently that was leaked, in our autonomous area. Actually most of the supervisor wasn't there yet at the time. So was able to like, help them and like, do this, do that, kind of redirect the patient so that they can continue, or we can continue giving the patient care, even though the issues still continue and being fixed by other departments. And I think that's what's giving me fulfillment. Like, I still feel like good, like, oh, that's like, I help, like, one, help the patient so the patient don't be waiting or have to be rescheduled. Two, I help save both the patients and the employees, like, moving them somewhere else where they could continue doing their job safely away from like the stores.
Yes.
What about Mars? Like, as like a staff, what do you think, how are like QA safety like practice in the lab, like for you as like a staff, like from, I guess, the bench point of view?
I actually did the interview when our facility had the opening for it, more so just for, I think, interview practice. But when I was doing a lot of studying about the position and stuff like that and what it entails, I also kind of felt like, I guess, what Nicole felt when you left the blood bank, how it's like, I don't know, do I really want this? Because you're kind of leaving to my interpretation at the time was like performing the direct testing on the patient and then going through the diagnostic process and like helping that way. But after having this discussion with you, Nicole, I can see like it's actually very super important. Like you said, the second most important role of the laboratory after the like directors and managers, because ultimately this position, you're the ones able to make change because there's always room for improvement. And like you
Yes.
guys are the ones who are getting it done. And so I was also like the liaison between those outside of the lab and the communication. So even though you're not directly performing the testing on patient specimens and stuff like that, that is the impact that you are making on patient care. And I would see that as like the best rewarding part probably of your position. Thank you.
Yeah, and so QA and safety were not just like a paper pusher. It's a lot involved in it, and it is still part of patient care ultimately. And that's what actually everybody in the lab was there for, like for patient care. We may do different part providing different aspects of our like duties, but the goal is for the patient, to improve the patient care. So yeah, that's kind of always is and always will be.
Before you continue, something else that, when I left the bench that I didn't really think about when it came to this type of job is when you're working on the bench and you are sick, someone else comes to take over for you. But when you are quality
You
or
are it.
safety, I mean, I'm very lucky to have one other person at my facility who is so knowledgeable. I love her so much. But she's been doing the job for a really long time. She is a wealth of knowledge. She knows everyone, and we make an excellent team. So I'm very blessed to be able to work with her because we, have the same heart, I would say. But something I didn't realize is no one covers for you when you're not there. And so you take a week off for vacation and you come back and you have 500 emails that you have to go through. Some of it's junk, but some of it is really important. And so,
But regardless, you have to go through them. Like to even say that, oh, this is a junk mail. Like you still have to go through it.
yes. So that was something I was not prepared for at all. Like, it is always nice knowing that if you aren't the one that is delivering patient care, someone else will. Like if it's a 24-hour facility, it has to happen one way or another. And that is like a huge aspect of management and leadership that I really respect because, I don't have staff that I am directly managing. Like that is its own thing. And I'm really glad that I don't have those responsibilities because, it's very challenging. But not being able to like have any sort of coverage or any help, like you are the subject matter expert when it comes to quality or safety. There's no one
People
else.
look up to you.
I mean, they notice when you're not there for sure. Sometimes, you're just in your office, like plugging and chugging away. There's a lot of data crunching associated with this position. But, when you're out, when I'm speed walking around the lab, like people know something's going on.
So what do you look for? Like you said, like you're, like speed walking through the lab, but do you do that every day? Are you looking for something, in like prevention aspect, I guess, like that you look for?
Well, we have discussed that every single day is different. You never know what's going to happen. You can't plan for emergencies. So sometimes if I'm running around, there might be something that like needs my in-person help, or there might be interdepartmental inspection happening or an audit or a tracer or something like that. So that might be when I'm out. I also do something called environmental rounds, which that occurs quarterly. Each area at our facility does what's called a safety survey, in which they essentially have like their own checklist of things that need to be done to ensure that it's a safe environment. And it's mostly environment. There's no glass stored on the top shelf. So in case like the cabinet got hit and it would fall on someone, or the sharp container isn't overfilled, or the trash is being taken in a timely manner and it's not like overloading, or there's no leaks. So, if you have a ceiling tile that's stained, like that can be mold, or, or maybe your refrigerator is leaking. So the safety survey, each department, they have their own tailored list of things that they need to go and check. I mean, sometimes if you're in the lab and you see the same thing every single day, like for instance, I did environmental rounds recently and the -80 refrigerator, it's a -80. It's not getting defrosted really ever. Sometimes eventually it does, but if your backup is all the way on the other side of the department, it may not be happening as often as you would like. And so in this case, when you open the -80 fridge, there's like a lot of ice particles that like fall down and would like make the floor wet. So the staff were using like a towel and the towel was gross and we had infection control with us. And I mean, if I had seen it, my eyes might have just washed over it because I've seen it there so many times, as with all the staff. But the infection control people saw it and was like, what is that? And why is it there? Is the freezer leaking? Like, and then all of a sudden I had to find out, why is it there? And turns out the freezer is working. It's not leaking, but it's just full of ice and it was like sprinkling down and creating a wet floor. And so their suggestion was don't use linen, use those absorber pads because they're disposable. So as soon as they get soiled, then you can just throw it away. And so I was talking to the leadership in the area and I said, well, you have a cabinet right next to the -80 that it's like a sliding cabinet with like a window in it so you can see what's inside. That is not being used. Why don't you put a couple of those pads in there? And so then you have a trash can right here. So if it's soiled, staff can just replace it without even having to take an additional step. And they were like, oh, that's a great idea. Because sometimes you'll make a suggestion and they're like, no, that's too much work. But it is very satisfying when the solution
works.
Yes. And it's
So
just
everybody benefit, right?
everyone
There's
is on
always
board
room for
immediately.
improvement.
Yes. Continual improvement is a huge aspect of quality. And some other things that I would do on a daily basis is data crunching, or responding to complaints or reviewing the canceled specimens of the day. Sometimes there may be collection issues. For instance, we had a situation in which our heparinized syringes that we were using for blood gas was backordered. So the syringes that looked identical were unheparinized. And if you're drawing blood gas in an unheparinized tube, it's just a giant clot. And so we were just getting all these QNS, all these clotted blood gas specimens. And so obviously there's a problem. We found out that you're using the wrong type of tube or the wrong type of syringe. We don't have any others that are the 3 ml size. So you have to use the 1 ml size, which if it is not full, if it is not no clot, if it is not collected appropriately, you have one shot to run that specimen accurately the first time. And so it was a huge challenge. And we had to pretty much monitor the usage on a daily basis with all the floors that were seeing that shortage. So another one was we had our sputum specimen, conical tube, a patient will cough into it and collect a sputum sample. They discontinued the one that our hospital had been using for years and years and years. And so our staff had to learn how to use a new one. The collectors were thinking that the funnel that sits on top of it that the patient can cough into was part of the lid, but it wasn't. And so what would happen is they would think that the lid was secure because it's secure on the funnel, but the funnel is not secure to the tube. And then they'd put it in the biohazard bag and then deliver it to the lab and it would all have spilled out. So tracking issues as they arrive on a daily basis is sometimes necessary. I also do a lot of, like I said, data crunching. I love me Excel. I love Excel. I'm often doing Pareto charts or, you have your Levy-Jennings if you're working the bench. Everyone knows the Levy-Jennings charts. Love a stacked bar chart. I want to be able to take all of the data that I am assessing on a daily, weekly, monthly, quarterly, whatever basis. I want someone to be able to look at that data chart and understand completely what's happening. So it's a lot of like fine tweaking, color coding. Sometimes I'll go to a quality meeting and the charts are just awful. And I'll just be like, what is even being said here? Like, so it's nice to be able to quickly look at a chart that I've been building, maybe over the course of the last 3 years to track, if it depends on how long you're tracking something. Like you might see, well, in July, when we have the new residents start, all of a sudden you see more errors of a certain type occur during those first few months, and then they're kind of addressed as the staff like learn the SOPs better.
Systems.
It's a lot of data crunching, a lot. And being able to give data in a clear, concise summary gives clarity to the management who is ultimately the ones making the decision on how policy is.
Yeah. And I have to agree with Nicole. I think before I used to hate Excel. Excel were not my best friends before, and I think I do learn to love Excel and use it a lot when even right now. But I think I start learning and liking Excel since I was doing QA and safety because you have to track a lot of data. There's so many aspects to it, and Excel can take a lot of those jobs, turn it into like charts for visuals. People like it's for like visual clue,
Yes.
and they can do that easier than I think like let's say Word or like something else would have done. And I learned to use it, but like in the beginning, it's like, oh, Excel, really?
Yeah.
I didn't like it before, but now I think it's something that I use every single day.
Yes, it's such a great tool. I'm always learning new things in it, but something that, you'll often hear in the lab is if it wasn't documented, it didn't happen.
Mhm.
And quality is all about documenting and providing evidence because there's always like action thresholds for everything. If you exceeded the threshold, you have to stop testing, you have to do all these corrective actions, and then you have to prove that those corrective actions are effective. And so to do that, you have to provide data. And if your data is a jumbled mess, you're not going to convince anyone of anything. So
Mhm.
I have found, like when I first started,
Lulu is very active today.
the position, a lot of the reports like were kind of older, and like maybe there were 3 reports all about a similar thing, and I combined them into one report so you could see how those 3 reports affected each other, and you may be able to see, you know, uh, shifts or trends that are being impacted by those different things on one chart. So sometimes it does make things a lot easier when your data, like, if you programmed your chart or you use a pivot table and it just does the work for you, that helps a lot. But there's always a lot of work in the establishment of that type of chart or data like form that you're using. And of course, then if other people are the one giving you the data, you also then have to train them on how to use the chart or how to take the data accurately. That's actually something that laboratory heterogeneity is something that is like a big deal in quality. Like this is probably the main reason why we do proficiency testing. You want to be able to, every lab is testing the same unknown and you're comparing your result with
Mhm.
all the labs of similar type. So you might be a teaching hospital, you might be a military hospital, you might be, just doing wave testing or whatever. There might be different things that lump you in a different group. And then
Mhm.
your instrument also has different ranges. So you might order, this is the Beckman Coulter instrument, this is the Roche instrument, and then you can't use the same kit. You have to use
Yeah.
them per instrument. So it is very interesting to be able to have that kind of data because then you can assess the effectiveness of the QMS of multiple sites and see if you think like, we're so good, we're meeting our threshold goals, like everything's looking great, and then all of a sudden you are at like the 90th percentile and everyone is down at like 10% above the mean. Like it opens your eyes to how other sites are doing it. And so the data is your measurement of how you are actually doing as a lab. Like, if you just keep your head down and you have a goal that doesn't really have any meaning,
Mhm.
like,
Yeah, like if you, yes, have a QA indicator, but like that indicator keeps saying like 99%, 100% month after month, maybe it's time for you to rethink about that
yes.
indicator. Like it shouldn't be just something to be like, oh, just keep this one so that I can be proud of myself because every single month it is a 99% or 100%. It's that, it just mean that, because in laboratory, there's always, not just in laboratory, in life, everything, there's always like room for improvement. So if you just stuck into that indicator and just already proud and be satisfied that it is meeting the thresholds, like, are you stopping the improvement from happening?
Yeah, I mean, if you're not collecting data in a meaningful way either or analyzing it in a
Mhm.
way that people are finding useful, like you might just be making work for yourself. So you need to
Yeah.
work like smarter, not harder, and you don't want to double work over it. Like quality is a lot about like it takes so much work, a lot of planning and discussing with other people and getting their expertise. And you also want to make as many people happy as you can, which can also be extremely challenging.
Mhm.
Um, you are always just looking for improvement across the board. You want everyone to be
Yeah.
happy. Sometimes that's not possible, but, um, And, it's another thing about, a stable function of data that you've been monitoring. If it's like 100%, 100%, then it's time for you to think like, oh, well, maybe we should stop monitoring this. But sometimes you are required by law to monitor it. So it is very scary when you are not knowing what is required by law versus what is best practice. So you really need to know before you make a suggestion to leadership because they are trusting you to know. And God, it is a lot. Like reading rules and regulations and standards and contracts and just the
Putting
constant
them
updates.
together. Yeah.
It takes so much time. It's very tedious. And I know that, I take on those tedious tasks. So the staff who are delivering patient care can do that. They can focus on that. But wow, it's a constant vigilance when it comes to quality because like you both said, quality improvement is a huge aspect of quality as a whole, and it doesn't matter how many projects you've slam dunked. There's always going to be more. And even if it seems like there's not, then another department says, oh, we need it. And you're like, well, what am I supposed to do? Like, I have fixed everything. And they're like, well, we'll work with you and we'll come up with something. And so there's always going to be a project no matter what.
Do you think, I guess, the program or the school prepare us enough to be in a QA positions? Or do you think if somebody who is going into laboratory and really interested in QA, like, what good habits that they can build, that they can observe early on, so that will be helpful in their career?
Well, to answer your first question, do the laboratory
programs
focus on quality? No, they do not.
Yeah.
And I mean, both of us know there's probably like one chapter that kind of gives you the bare minimum. Like I remember I had these flashcards. I don't remember which ones it was, but there was one card on laboratory management and one card on quality. That was it. And I think there might have been a question on all of the like prep exams that I have taken each. Clearly, it's just there because they have to include it. But as a student, like, of course, if you've worked in a hospital or a clinic, like you have a greater understanding of like how the laboratory works in reality. But if you don't have that, you can only have your theoretical understanding plus whatever you're learning during your clinical rotation. So it's very difficult. Like if I went back from when I had just graduated, there's no way I would have been hired as a newbie into a quality position. I don't know anything. I don't think there is a clear path to get into quality right away. I feel that a lot of it is you need to learn on the job in different types of labs and different types of environments with different people. And it comes with experience. Like I remember when I first started, I was so jealous of all my coworkers being so confident in being able to just follow the SOP from memory. And I was like, why can't I just be there and just do things quickly and efficiently?
And with confidence, right? With the confidence.
Yes, but when you are a brand new CLS, there's a lot of responsibility and accountability that comes very quickly. Like when you're training, you're not signing anything off, like you're not resulting anything. You have a trainer with you. They are using their sign off. They're watching you. They are responsible for you. But all of a sudden, as soon as you're trained, you have been incompetent. You are signed off to work on your own. And that is very scary for, having just been out of school. I would say some things that I would say to trainees or new CLSs or students in the program, like there are a couple things that you can always take with you wherever you go. Rule number one, everything is traceable. So you need to cover yourself. You need to take accountability for your own actions. If someone is asking you to deviate from the SOP to make their life easier, don't do it. Like, because your name is going to be associated with that deviation. The process is in place to not only protect the patient, but also to protect you from potential litigation.
Hi, welcome to Blood Talk Small Talk, where we aim to provide a deeper understanding of the teamwork it takes to ensure quality care in a healthcare setting. Tune in for a mix of serious science and casual conversation, and you might be surprised to learn just how much goes on behind the scenes. I'm your host, Mars.
I'm your host, Pich.
On today's episode, we'll be talking a bit about something that doesn't always get the spotlight, but absolutely should. One of the misconceptions about the lab is that all we do is run and release tests, but there is so much more to it than that. Today, we invited Nicole, a CLS Quality Assurance and Safety Coordinator. Nicole, would you like to introduce yourself and a little bit about your background and how you grew into this role?
Yes, hi, I'm Nicole. I am a CLS, and I first started about doing blood bank for about 6.5 years, and then an opportunity to move into quality and safety presented itself, and I decided to go for it. With blood bank, everything has to be like very particular and recorded and documented. And so we already had a little bit of that, very detail oriented aspects in my work. So I went for it and I really like it. But I do want to say that I am not the coordinator at my facility. I am part of the quality and safety team though.
Congrats still. Still hard work, man.
Yes. It's really hard. It's very detailed. And actually, Nicole plays out herself. She's very, very detail-oriented professional. It's just even when we were in blood bank together. So
yes,
I think it's a very good trait to have, especially to grow into like a QA and safety roles. So
I've been doing quality and safety for about 3 years now, and
It's been 3 years already? Wow.
yes, it really
Kind of
flew.
fast, isn't it?
Yeah, it sure did, and I've learned so much and have so much still to learn. I mean, the environment is constantly changing, which we will talk about in detail as we keep going.
Yeah, let's start. So if someone outside of the healthcare, how would you describe or tell them what's QA and safety? Like, how would you explain it?
Well, I would describe it as being the person to essentially make sure that the laboratory is compliant for all regulatory and accreditation requirements. What does that mean? Well, there are all these different organizations that the laboratory has to follow these standards. So essentially, you can feel like the results that are being put out are accurate and reliable because if the laboratory is not putting out something that you can rely on and doctors can make diagnoses on or interpretations based on those results, what is the lab even doing? So with quality, you've got CAP, the College of American Pathologists. You've got CLIA, which is the Clinical Lab Improvement Amendments, the Joint Commission, CMS, OSHA, the FDA, goes on and on and on. Plus, and
The
those
whole
are just,
alphabet.
yes, it's really just, there are so many things that you have to consider. Finding the appropriate standard, making sure that like the spirit of